I get the honor to introduce Dr. Paul Grayburn, Medical Director of Non-Invasive Cardiology at Baylor University Medical Center in Dallas. He's going to talk about MitraClip today. Dr. Grayburn is an international name in imaging, aortic stenosis, mitral valve, numerous papers in the system, and we're honored to have you here today to talk about MitraClip.
Yeah, that's good. If you want. Yeah. That's good. Yeah, fantastic. Yeah, it's great to be here. You know, I was at the VA for 16 years, I think. And it was great to see Dr. Banerjee's slide where it's the same cath lab crew that I worked with all this time. It's still there. I love those guys, Dawn and Gracie, Susan, and Cheryl Webb-Singh, who was my assistant before she became Subhash's. So it's good to be here. Thank you very much. We're going to talk about percutaneous valve therapy, and I'm going to try to go fast. I do have a lot of disclosures in this space. I consult for a lot of these people. I do research trials for a bunch of them, and I also do core lab work. I just added a core lab contract. It's not on the slide for Tendine. That just happened. So all of this is, you know, I'm very involved in this. I think it's kind of funny about the disclosure thing. You know, I've been to a number of FDA panels for approval of these things, and usually the people on the panels are not experts in the field. Usually they don't. So when we presented MitraClip, there wasn't a mitral valve surgeon on the panel. And the reason is, if you have no conflicts, you're not an expert. You know, and so the federal government has this rule that you can't be conflicted. So there's nobody in there that knows anything about the field. Too bad. Anyway, that's life, and we have to deal with it. So I'm going to talk about three things: percutaneous annuloplasty, edge to edge, and then transcatheter mitral valve replacement. So we're kind of going to go fast. Before we get into this, it's very important to separate primary from secondary MR. And I think everybody knows that now, but as you go back and look through the literature, these are mixed and jumbled up, and it makes it hard to interpret and understand the literature. So in primary MR, something's wrong with the leaflets themselves. The most common thing is mitral valve prolapse. And we know from Blaise Carabello's famous quote, it's the valve that makes the heart sick. Fix the valve, the heart gets better, the patient gets better. So we know that in primary MR. And we also know that surgical valve repair is the gold standard. A good mitral valve surgeon, Dr. Jessen is one, can repair these valves with a very high success rate, high durability, and very little mortality. Now, secondary MR is totally different, and it's controversial. The leaflets are essentially normal. They're not the problem. There may be some minor calcification in an older person, but the problem is the left ventricle. It dilates, it pulls the leaflets apart, it tethers them, and so it's not really clear if fixing the MR is beneficial or not. And most of the data have not shown a benefit, or at least not shown a clear benefit. So surgery is actually listed in the guidelines as a class 2B option, level of evidence C. And it's generally thought that you would only repair the mitral valve if you have to do a cabbage anyway, and it leaks a lot. So there's still a lot of debate about that. Now, I borrowed this slide from my buddy Craig Miller. He and I are usually the only guys wearing cowboy boots at the meetings, and he's divided this up into the black hats and the white hats. The black hats are flexible or incomplete annuloplasty rings, and they don't work very well. The white hats are various types of complete rings that are stiff or rigid, and they come in different shapes because every mitral valve surgeon who's worth his salt has a patent on one of these, and it's named after them, you know, or so they say. But that's changed, and I'm not going to go over the CTSN trials. I'm privileged to be an investigator and on the steering committee, a part of this incredible network. But as you probably know, there was a big trial that came out a little more than a year ago in the New England Journal, and they took patients with severe MR and randomized them to get a replacement or a fixed rigid ring. And this was done in the best centers in the country by the best surgeons in the country, and they used the right kind of rings, and the rate of recurrent severe or moderate MR at 1 year was almost a third of the patients. So now the whole field is moving more away from rings and toward replacing these valves, especially if the posterior leaflet is fixed and immobile. Putting a ring in doesn't necessarily fix that problem. And I think that's kind of a death knell for all of these devices, such as this one, the Carillon device, who try to do annuloplasty percutaneously. So this device, you go in through, here's the tricuspid valve, here's the mitral valve, you go in through the coronary sinus, just like you're putting in a biventricular pacemaker lead, and you put this anchor here, and another one here, and then you can tighten this up and try to pull in the posterior leaflet. But remember what we talked about, the surgical approach is a fixed, rigid ring. The annulus doesn't go all the way around the mitral valve. So this doesn't even make any sense. And there's other things that fall into play here. So the coronary sinus, as you'll see in a minute, is superior to the annulus. It often overlies the circumflex artery and can lead to acute MI. CT studies show this happens in about 2/3 of patients, and some studies even higher. The coronary sinus, as I just said, doesn't allow a complete ring. And so indirect mitral annuloplasty versus the coronary sinus is dead. Not going anywhere, it shouldn't go anywhere, and we shouldn't do that to our patients. That would be wrong. There are some transcatheter direct annuloplasty devices out there that try to mimic what a surgeon might do. One of these is to put two pledgeted sutures on each side, sort of P1 and P3, and then tighten those up. They're placed through the ventricle coming up into the atrium. That's called the mitral line bident. Then there's the guided delivery systems AccuCinch, where one tries to actually, using a catheter that sort of looks a little bit like an Amplatz one. You kind of go under the aortic valve, turn, and try to steer behind all the cords and do a subannular cinching, pulling the ventricle in. And then there's the Valtech Cardiobands, a company in Israel. I'm their Echo Core Lab, so I know a little bit about this. And here you start by putting an anchor at the lateral trigone, marching all the way around medial, and then cinching this up in a live beating heart. And here's how those work, just to show you. We have an instrument here in the coronary sinus, so you see where that sits. Here's the circumflex. If you pinch this in, you could occlude the circ. And you see the coronary sinus is far away from the mitral annulus. This is actually the annulus right here. So the Valtech device tries to mimic a direct surgical annuloplasty by going right into the annulus. Mitral line is here, guided delivery systems is here, and all of these are trying to pull that in. Here's the first Cardioband human implant. This was done in Europe, and you can see that it looks like an annuloplasty ring, and it's kind of cool because it allows you to adjust the size of the annuloplasty in a beating heart while you're looking on echo. There's a study that's been completed of 30 patients, and we'll be presenting that data. I can't show it to you. Transcatheter mitral valve repair. This is the MitraClip, and this is approved by the FDA. And I know a lot about this because I presented it to the FDA. And essentially what we're doing here is putting this clip on the mitral valve and pulling the anterior and posterior leaflet together at the site of the leak. And this distance from right here to here is about 9 millimeters. So it forces 9 millimeters of coaptation, which I think is actually better than an Alfieri stitch. This was unique when this was published in the New England Journal because it was really a rare and at that time the first randomized trial in mitral valve surgery that was really well done and multi-center and all that. And it showed that surgery was superior to the MitraClip in reducing MR. So surgery remains the gold standard, no question about that. But MitraClip was technically, statistically significantly better than surgery because of one thing, and that's a lower risk of transfusion. You can argue whether you think that's important or not, but MitraClip is safe and it's effective, just not as good as surgery. Worldwide, over 18,000 patients have been treated. Nearly 2,000 of those have been in prospective clinical trials, and almost all of them are considered high risk for mitral valve surgery, because remember, mitral valve surgery for primary MR is still a very fine gold standard. The bar is so high that nothing is going to ever beat it. Yet the FDA approved this in October 2013, and here's the language, and the key point here is it's for primary mitral valve regurgitation, not secondary, and specifically degenerative MR. And they have to be determined to be at prohibitive risk for mitral valve surgery by a heart team. Cardiac surgeon experienced in mitral valve surgery has to be involved in that. And so the definition of prohibitive risk is basically a 30-day STS score of 8% for replacement or 6% for repair. Hard to get to this. If you look at the STS database, only 5% of the patients in there have scores that high for mitral valve, for isolated mitral valve surgery. Of course, they could have something else. So if they don't meet this, but they had a porcelain aorta, they were very frail, hostile chest, liver disease with a MELD score above 12, severe pulmonary hypertension, and then other extenuating circumstances. And boy, we had a big fight with the FDA and had to educate them on stuff like this. They would say, this patient's not high risk. And we would say, Mark Gillenoff, one of the most experienced mitral surgeons in the world, turn them down because they're on chemotherapy and have no white count, no platelets. You wouldn't operate on that. Of course they're high risk. And we had to kind of teach the FDA that there are certain things that don't fit into the STS score that any surgeon in the world would say no to. And so they allowed us to put those on. And that's a good thing. Now here's the data that the FDA used to make this determination to approve this. We took all of the high-risk degenerative MR patients in all the U.S. trials that had 1-year follow-up, and we reviewed them. So there were 141 of them, and Mike Mack and Pat McCarthy and I reviewed them and determined that only 127 of those, most of them, actually met prohibitive risk definition. So there's always creep in clinical trials. There's always people that get in that probably shouldn't have. And so we took those 127 patients, analyzed the data, published it in JACC, as you see here, and then presented it also to the FDA. And here's what the patients look like. They get MitraClip or should get MitraClip. They're elderly, and they have lots of comorbidities. You can see 84% of them are over 75. And you look down the list of comorbidities, these are high. You look at the STS risk score, 13%. That's extremely high for mitral valve. So these are people really that shouldn't get an operation. When we compared them, we saw that the STS predicted risk score was a 13% mortality. We were 6.3 when we put a MitraClip in. So that was good. It was statistically significant. MR is reduced. 90% of these patients had 3 or 4 plus MR. The core lab, of course, threw out some of them and said they really had 2 plus MR, and this speaks to the difficulty of grading MR and echo. But you can see that that's completely reversed. At discharge, 85% were 1 or 2 plus, and then at 1 year, in the surviving patients, 83% were 2 plus or less. So when a surgeon repairs this valve, they're not going to be 2 plus. They're going to be 0 or 1 plus. And so that's the difference. But nevertheless, we show that these patients do get better with the clip. I don't want to go over this slide just to point out how complex it is. Here, this is baseline to discharge, discharge to 1 year. If you look carefully, you'll see there are patients who were 1 plus at discharge and wound up 3 plus at 1 year. And there are patients who are 3 plus at discharge, you had 1 plus at 1 year. That's just the way MR is. It's dynamic. Echo isn't perfect. It's especially imperfect after a MitraClip. Imagine putting your thumb over a water hose and making a big spray. The color Doppler looks terrible after a MitraClip. We do MRIs and some of these people with big color jets and they don't have any MR at all on MRI. So this is complicated, but we have to look at other things too. So LV volumes get smaller. A substantial reduction, about a 15% reduction in end-diastolic volume, not much reduction in end-systolic volume. This is what you would expect for fixing primary MR, which is a pure volume overload on the LV. You would expect end-diastolic volume to get better, but not end-systolic volume. Functional class is very impressive. 87% of these patients were class 3 or 4 heart failure, and that completely flipped around at 30 days. And then in 1 year, 87% of the survivors were class 1 and 2. So these patients feel a lot better after a MitraClip. And this is the SF-36 quality of life score. You're probably not used to looking at this, but at baseline, these people have low scores for physical and mental components. And then at 12 months, they reach the age-adjusted US norm. So they go from being severely ill to being normal for their age. And this little bar here is the minimal clinically important difference. So they cross that easily. for both mental here and physical here. These patients feel better in a very objective way. And importantly, if you look at the year prior to MitraClip in these patients versus the year afterwards, there was a 73% reduction in heart failure hospitalization. This is the safety, very safe, few side effects, but these patients are very sick. So there's a 6% mortality in 30 days and a 24% mortality at 1 year. Sort of like TAVR, they're sick patients to begin with. And if you break that down a little further, you'll see that the patients who have success, they get to 1 or 2 plus MR, have a good survival rate, over 80%. The patients in whom the clip doesn't work, and there's only about 15% of those or less, have a 50-50 chance of being alive. So when you put the clip in, you have to get it to work. There have been, when I made this slide last month, there were 1,167 cases done commercially in the U.S. There's over 1,200 now. We're going to present the data at the ACC in San Diego. Now I'm going to move on real quickly to transcatheter mitral valve replacement. The clip isn't perfect. It works well in selected patients, but remember, it doesn't always get you down to 1 plus MR. And so the idea, and I also showed you the data from CTSN, that surgeons are moving more toward replacing functional MR because repair with a ring doesn't work so well. So now we have different types of valves that we can put in percutaneously. And this is a Tendyne. It's one of several. I'm very familiar with it because I read their echoes blindly for them, and I've actually put one in a pig, and hopefully I'll be putting one in a human in about March. We're also putting human Fortis valves from Edwards starting in February. It's very interesting, and this particular valve is fully retrievable and repositionable. It comes in multiple sizes so that you can treat small, medium, and large mitral annulus sizes. And this is kind of what it looks like. So this is Neil Moat in Royal Brompton Hospital in London. He did this case in December, and I've got the images. This is Neil's finger right here. And no comments on what he thinks about us. It's just that he's doing this as is typical when we do a transapical TAVR. You want to see where you are. So the surgeon puts his finger at the tip of the apex, and we look on echo and say, yeah, that looks good. So he makes his incision there, puts in his plugets, and then we proceed. And so here you see the guide wire going out into the left atrium, into the left upper pulmonary vein, and then a sheath coming in over it just above the mitral valve. On 3D, it looks like this. We're looking down from the atrium down, so the ventricle is down in this hole, and this is the sheath coming just up and across the mitral valve. And then we begin to push the valve out of the sheath. It's a retraction device, much like the core valve deployment device. We've done 4 patients so far at various sites. All were discharged to their own homes. These are very sick patients, inoperable patients. And Jack has accepted our paper, so we have a paper in press at Jack on this device. And then this is a implant done in Sydney, Australia, in a functional MR patient. So here you have a 75-year-old man with severe functional MR, prior cabbage. He had severe COPD and was declined for surgery. So this is pre-op. Here's the device in place, and you can see there's no paravalvular leak. It looks really beautiful, and there's no gradient across it. So there, last slide, there are several of these out there. The Fortis valve is made by Edwards. We just got IRB approval and hope to start on February 12th with our first patient. Neovasc Tierra is one that's been used in the U.S., very interesting valve. Cardiac, this is Joe Bavaria's valve at Penn. He helped invent that. That looks like a very good valve to me. Tendyne, in my opinion, after looking at all these, I think this is the best valve out there right now. Medtronic has one, and then there's others in the pipeline. Just like TAVR, the future generations of this are going to be better, but I think this is really exciting, and we're doing this and looking forward to it. Thank you.